So good morning, everyone. So today I'm going to talk about approach to a patient with thyroid nodule. This is a very related topic with thyroid disorders. In the last class, we talked about hyperthyroidism or thyrotoxicosis and hypothyroidism. So you have already, certain concept from those. Now, this topic is a very clinical one and very common one actually. Whenever you start working in the hospital, in the endocrine clinic or ward or OPD, you will come across this type of case. Okay, a patient who has come with a nodule in the thyroid gland. So how to proceed further? What is the approach? How to take history? How to do physical examination? What is the first investigation you order? Okay, and how to manage. So let's talk about this in today's class. Just take it as a revision of whatever we have done in the last class. Now, see there, this is the way a patient may present. A 29-year-old female referred to head and neck clinic for evaluation of a thyroid nodule. So she already had a thyroid nodule and they have referred for the evaluation. Patient reports this nodule was found incidentally, okay, while she was getting ready for work one morning. So this was an incidental finding by the patient, and she is worried. That's why she went to, probably primary care physician, and that doctor referred her to the head and neck clinic. Now see that exactly happens. She went to her primary care physician, PCP, though this type of short form is discouraged for the students, okay, who ordered a thyroid ultrasound, which demonstrated a 2 centimeter nodule in the right lobe of the thyroid. So clear cut nodule was there, just 2 centimeter bigger. Now, after thorough history taking and physical examination, what would you order first for this patient? You have to choose one option from there. So there are 5 options given: thyroid function test, CT scan of the neck, MRI of the neck, radioactive iodine uptake scan, or all of the above. So what is the answer? What you go for?
TFT.
Thyroid,
TFT.
A, TSH,
Exactly.
thyroid function 10.
Exactly. Okay. So always remember this. Whenever this type of patient comes to us, the first investigation we order is thyroid function test. We want to make sure what is the status of the thyroid gland. It is normally working. Is it hyper functioning or is it hypofunctioning? We need to make sure about those. Okay. So correct answer. That is the thing we are going to do. And later on, we may need other tests as well. Now see that. So what you order first for this patient, the answer is thyroid function test, that is TSH and T4. T3 is a part of thyroid function test, but T3 is less important than T4. Okay. If T4 is less, then you can order for T3. It is like that. But sometimes there is a type of, disorder where only T3 may be affected. So to find out that, we definitely need to go for T3. It is important to first establish the patient's thyroid function. This will help determine if the non-thyroid nodule is hyperfunctioning, hypofunctioning, or non-functioning. That's what we just discussed. So this is the first investigation. Let's move on. At this point, you should also obtain fine needle aspiration with ultrasound guidance, because I want to make sure what type of nodule is that. Is it benign nodule or malignant nodule? Because there is a 2 centimeter nodule which was picked by ultrasonography. So let's take some cells out of that and send to the pathology lab, and they will give you the report whether this is a malignant mass or a benign mass. This is the second important investigation after thyroid function test. Now, what is else you want to take in the history after the routine, history taking? Always ask about family history of thyroid disease or thyroid cancer. Okay, family history of thyroid disease or thyroid cancer. Now, there is a condition which is known as familial, this MEN syndrome, means multiple endocrine neoplasia syndrome. multiple endocrine neoplasia syndrome, and it may run in the family as autosomal dominant disorder. So let me talk a little bit about this. Okay. Though I will repeat it again later on, but this is a very important knowledge for you. So let's talk about it. This multiple endocrine neoplasia, okay, are MEN1, okay, MEN1, MEN2, okay, 2A, and 2B. So there are three types: 2A, 2B, and MEN and 1. Now, what are the important feature of them? In MEN1, you have three P's. I'm making it very easy for you. Three P's. Now, three P's means, okay, can you guess what are these three P's? Anyone?
Pituitary, parathyroid, pancreas.
Parathyroid,
Parathyroid, pituitary,
pancreas, pituitary, and parathyroid.
pancreas.
Exactly. Absolutely correct. This consists of pituitary problem, okay, pituitary problem, parathyroid problem, very good, and pancreas problem. Now, usually they are tumor. From the pituitary, it is pituitary adenoma. From pancreas, they are pancreatic adenoma. And from the parathyroid gland, usually it is known as parathyroid hyperplasia. Parathyroid gland is bigger in size, okay, and it is producing too much hormone. So this is MEN1. Now, when we talk about MEN2, okay, sorry, 2A, now we have parathyroid hyperplasia. Okay, let me write that for you so that it is easy for you. Parathyroid hyperplasia is first one. Then we have medullary carcinoma of thyroid. Medullary, okay, cancer of thyroid gland is the second one. And third one is called pheochromocytoma. Pheochromocytoma. Now, what is pheochromocytoma? Yes, what is that?
So there is a
Tumor
Tumor,
of
tumor in the adrenal medulla which secrete the
medulla.
catecholamines.
Secret catecholamine.
Exactly, exactly.
tumor of adrenal.
Very good. It's a tumor of adrenal medulla. It's a tumor of adrenal medulla, which is producing catecholamine hormone. So this catecholamine hormone will lead to episodic increase in blood pressure and severe headache. It has a lot of complication associated with it. So parathyroid hyperplasia, medullary carcinoma of thyroid, and pheochromocytoma. This is 2A. Okay. Now the one more thing is left for us, that is 2B. So let's talk about it. What are the important features there? In 2B, we have got multiple mucosal neuroma. Okay, multiple mucosal neuroma. Neuromas means they are the benign tumor which originate from the nerve, neuroma. Then we also have medullary carcinoma of thyroid, the same one, medullary carcinoma of thyroid. We also have pheochromocytoma. Okay, pheochromocytoma. And one more feature you have sometimes in the patient, they have marfanoid body habitus. Okay, so marfanoid body habitus means they are quite tall type of person, and their, the uh, arm span is more than the height. This is called marfanoid body habitus. See that? Okay. Now, this is called ME1 syndrome. Now, let's come to the point. Now, why we need to, take this issue? Because they may run in the family. There are different malignancies, or different benign tumor, different disorders of the endocrine gland. So this is a very good history to ask. Okay, let's move on. Now, ask about the personal history of radiation to head and neck, because there is an increased risk of thyroid cancer in the radiation exposure. Now, there is one exception though. In the earlier textbook, okay, or a bit prior to like a few years, we used to believe that after doing one of the investigation in case of thyroid gland, or after treating any case of thyroid gland with radioactive iodine, there may be an increased risk of cancer later on. But many different researches have been done all over the world, and it has been shown that there is no extra risk involved when we treat the patient with radioactive iodine treatment these days. Okay, but having said that, if you use, for example, you are treating Hodgkin's lymphoma or non-Hodgkin's lymphoma with a radiation therapy, okay, then probably because of that, there may be increased risk of thyroid cancer later on. So a good history to ask. Ask about hoarseness of the voice, shortness of the breath, and difficulty swallowing. Now, all of these are compressive symptoms of thyroid goiter. Now, goiter is a mass in thyroid gland. It may be benign mass, it may be malignant mass. So this mass will give compression to the nearby structure. So if recurrent laryngeal nerve is affected, then we have got hoarseness of the voice. Shortness of the breath is because of tracheal compression, and difficulty swallowing is because of esophageal compression. So it is very easy, concept for you. Always ask this. And we usually think malignant tumor of the thyroid gland give rise to these symptoms quite early. But sometimes the mass is a benign one, but if it is a big enough, it may produce this symptom as well. Now, in this patient, now let's come. This patient reports her voice seems to have become slightly more husky lately. So there is a slight involvement of the quality of the voice. She recalls only occasional discomfort with sensation that something is pushing in, and she denies shortness of breath. Okay, so these are some additional problem with her. She denies any family history of thyroid cancer. So there is no, family history of cancer. She denies personal history of radiation therapy or thyroid or any other type of cancer. So this is a very good history we have taken, and many of the points are covered here. During physical examination, what components of the physical exam are critical for this patient? These type of questions are commonly asked to the students. So see there, we need to examine full head and neck to look for any lumps or bumps. Now, what do you mean by these lumps and bumps? What are the other things you are looking there apart from the thyroid mass? What else? Yes?
Lipoma.
Okay. Anything else? They are the lymph node.
Nodules.
Lymph node.
Any. If not.
Exactly. They are the lymph node. Don't forget that. If this is a case of malignancy, then usually, it is associated with lymphadenopathy. So you need to feel for those lymph node there. This is the point. Okay. We try to mention here. But for the differential diagnosis, you may look for other mass as well. Palpate for lymphadenopathy, very important one. And you all know what are the hallmarks of malignant lymph node. If a metastasis has gone to the lymph node, then that lymph node will become very hard. Okay, it is hard. There is no pain. Pain occur only if it involves some nerves there, or if there is a massive swelling of that lymph node which is giving pressure to the nearby structure, then only pain occurs. Otherwise, a malignant lymph node is painless. The third important point, it infiltrates the local area. So it is not mobile anymore. And the skin which is overlying that node is also fixed there. So these are the hallmarks of malignant lymphadenopathy. Never forget it. Palpate thyroid for nodularity, firmness, or hard mass. We always do that. What type of mass is there in the thyroid? How hard it is? Okay, we need to feel it. Fiberoptic or direct laryngoscopy to evaluate the vocal cord function. This is another part of physical examination. We want to make sure whether vocal cords are paralyzed or not. Now, which nerve supplies the vocal cord? Which nerve?
Recurrent laryngeal.
Excellent.
Recurrent laryngeal.
Exactly. It's recurrent laryngeal nerve. It supplies the vocal cord. So anyhow, if that recurrent laryngeal nerve is damaged, then, okay, the vocal cord function will be affected. When we examine, the vocal cord may come near to the midline. Now that is very abnormal one. Vocal cord, when patient is breathing or when patient is producing sound, the vocal cord should move. There is usually abduction of the vocal cord during inspiration. So this is a very important point here. So we should always check vocal cord function by fiber optic or direct laryngoscopy. Now, on physical exam, what is there in this patient now? Those are the things which we have to do in all patients, but what finding this patient is having. Let's talk about it. On physical exam, you palpate a grossly enlarged thyroid gland with a 1.5 centimeter dominant nodule on the right thyroid lobe. So this is the finding in her. So there is definitely nodule and the thyroid gland is grossly enlarged. Now you discover the following findings on fiber optic exam. See there. Now, all of you, please pay attention there. Here, this is a bit of ENT actually. This is the view of the larynx, and this is the picture from the patient, the same patient. But before that, I want you to concentrate here on the next picture. This is how we see larynx on laryngoscopic view. Now, see this. These two white cord-like bands are the vocal cord. They are the vocal cord. This is anterior part and this is posterior part. Okay, this is the base of the tongue. So you need to depress the tongue with laryngoscope blade and then look on the larynx. These are called false vocal cord. Okay, false vocal cord. We are not concerned about the false vocal cord here. We are concerned about the true vocal cord. See there. These are the ones. This is epiglottis. Epiglottis is a laryngeal cartilage. We all know that. Okay. And here is the trachea. If I see below the vocal cord, then these are the tracheal rings. So trachea is seen there. And here is the opening of the esophagus. Now, exactly, this is a schematic diagram and this is a real patient diagram. Now, see, a real patient picture, I should say. Now, see this, these are the vocal cord. These are the two vocal cord. These are the tracheal ring I can see. Okay. This is epiglottis. Epiglottis. So here is anterior side, here is the posterior side. So upon inspiration, when we ask the patient to breathe, there is symmetrical bilateral vocal cord abduction. That means they are not very affected here. Probably recurrent laryngeal nerve was not damaged in this case. Now, another important investigation they have done FNAC or FNA, whatever you want to say. This is fine needle aspiration, or we can also write fine needle aspiration cytology. Okay, so patient returns to clinic the following week with FNA report reading follicular cells and cannot rule out follicular neoplasm. So FNAC is not that very helpful in this lady, because it says it cannot rule out the follicular neoplasm or follicular cancer. Then what's the use of that, right? We cannot believe that report. So we need to go for some other type of examination, probably biopsy, okay, probably surgery. So this type of things has to be thought. Now the question is surgery indicated for your patient at this time or not? So what do you think? Is surgery indicated or not? Yes or no? What is the answer?
Yes.
Yes, sir.
Yes, sir.
Yes.
Absolutely, it is indicated because FNAC is not that very helpful. So we have to go for surgery. We still believe this may be a case of malignancy. Now see there, surgery is indicated. The follicular cells on FNA can be a benign finding or may indicate follicular carcinoma. That's why it is strongly indicated. And follicular carcinoma cannot be diagnosed only by FNAC. So we need a solid chunk of tissue to diagnose it, and that is only obtained by proper biopsy. Now, we usually go for hemithyroidectomy for tissue diagnosis. means which side the mass is there, you want to remove that part of the thyroid gland, and don't remove the another part of the thyroid gland which is not affected, because that is not usually done. We usually do not go for complete or total thyroidectomy. Patient needs thyroid gland, patient needs thyroid hormone. So if possible, you don't go for total thyroidectomy. But having said that, sometimes we need to go for it. If there is involvement of both lobe of the thyroid gland with malignant cells, then we need to go for it. Now, tissue taken at the time of surgery must be sent for pathology to evaluate for extracapsular extension, lymphovascular invasion, or metastasis. The surgeon is doing the surgery, and at the same time, the surgeon can send that mass or that sample for the histopathological examination, and the surgeon waits for that report. It is a quick type of report, and if the report comes as a malignant mass, he can go for some detailed type of surgery. That is the meaning. Now, in the case that follicular neoplasm is suspected based on, history and physical exam and FNA result, patient should be taken to surgery for pathological diagnosis and treatment. Let me repeat again. If you suspect follicular cancer or follicular neoplasm, don't only rely on FNAC report. You need to take the patient for surgery, take a good piece of tissue, and send it to the histopathology lab. Now, having said that, what are the indications for thyroidectomy? Very important questions for the students in the exam. See this. What are the indications? If the patient is having features of hyperthyroidism like Graves' disease, which is not responsive to medical therapy with a lot of ophthalmic symptom, we need to go for hemithyroidectomy, okay, or subtotal thyroidectomy, whatever is necessary. In Graves' disease, both lobe of the thyroid gland are affected, so I'll rather go for subtotal thyroidectomy than only hemithyroidectomy. Now, one small question, a bit of revision from our previous discussion. What are the medical therapy of Graves' disease? Yes, what are those?
Sir, we can give the different kind of drugs
Okay,
like
just take the name. So just take
propyl
the name of the drug. Yeah, just take the name.
thiuracil,
Okay.
methimazole,
Beta
carbimazole,
beta
propyl
blocker
propanol,
and
propyl
pro,
thiuracil,
carbimazole.
While Thyroid, we can also give beta blockers
propranolol
like
and
propranolol.
propofol.
Very good. Very good. So I can,
propranolol.
yes, I can hear the answers of all the students there. Good. So you are answering. We should start with anti-thyroid drug like propyl thiuracil, carbimazole, or methimazole, any one of them. Along with that, we have to give propranolol because Graves' disease is one of the important cause of thyrotoxicosis, and we need to control all those sympathetic symptoms there with propranolol. So these are the two very important drugs. The third one, okay, the third one is radioactive iodine treatment. Don't forget that. So it's a patient choice, which is they want to opt. So accordingly, we need to decide. Radioactive iodine uptake or radioactive iodine treatment, I should say, is one of the very important treatment because it destroys the thyroid gland and it treats the case of thyrotoxicosis, but it also converts the same patient to hypothyroid patient. So after we treat them with the radioactive iodine, we need to supply thyroxine hormone for the rest of the life. These are the different medical therapy. If they fail, we don't have any option. Let's go for thyroidectomy. Now, another is malignancy, confirmed or high suspicion. See there? So let me underline these things for you because these are really important one. If there is a malignancy which is confirmed or highly suspected based on history or FNA report, you need to go for thyroidectomy, either subtotal or total. Goiter with compressive symptom, you need to go for decompression surgery. So thyroidectomy is a part of that. And if there is a large thyroid nodule, which is more than 2 centimeter, that is unable to be adequately sampled by FNA, just like in our case, okay, just like in our case, especially we are suspecting a little bit like a follicular carcinoma and FNA is not that helpful, then to have the larger mass, we need to go for thyroidectomy again. Okay, let's move on. Now we are coming towards the end of this very important clinical discussion. What are the etiologies of thyroid nodule? Another important question for you. See there. So we divide this nodule into benign and malignant. So benign nodules are benign thyroid cyst, which are usually caused by degenerated nodules. Colloid nodule, they have lots of colloid at the center. Okay, these colloid are having the precursor hormone there, and multinodular goiter is a common cause of thyroid nodule. Okay, these are the benign. Now let's go to the malignant side. We have got papillary carcinoma of thyroid gland, we have got follicular carcinoma of thyroid gland, and one of the type of follicular carcinoma is called Hurdle cell tumor. This Hurdle cell tumor is developed in Hashimoto's thyroiditis. We'll talk about that in our thyroid cancer class. Third one is a medullary thyroid carcinoma, and the fourth one is anaplastic carcinoma. And sometimes even lymphoma of thyroid may occur there. Okay. Now, this papillary, follicular, medullary, and anaplastic are pure thyroid cancer, whereas lymphoma of thyroid may be developed there or may reach there after metastasis. So these are the etiologies of thyroid nodules. Okay. Now let's move further. Now let's talk about what are the important investigation you order if this type of thyroid nodule case come to you. That case was a very good a concept for you, but you need to know something more than that. Okay, now see here, CBC is usually done. Okay, this is one of the routine tests we always do, complete blood count. And who knows if this is a case of malignancy, if it is a stage 3 or stage 4 malignancy or terminal cases of cancer, then bone marrow may be affected. And if bone marrow is affected, there is pancytopenia in any case of terminal cancer. Apart from that, different biochemical test has to be done. Liver function test, renal function test, okay, LDH level, and all those things can be done. Now, thyroid function test, already talked about. Level of parathyroid hormone can be assessed there. Now, why parathyroid hormone is assessed in a case of thyroid nodule? Anybody? Why? Yes, Rana Atisam, say it again.
It's just behind the thyroid.
Yes. I'm listening. Yes, answer.
So the gland is present just in the thyroid.
Okay, that is one good
The
answer.
thyroid gland is present just behind.
Okay, another one. What is another explanation?
Sir, if the thyroid hormone are normal, it means the problem is only in thyroid gland.
Now listen, okay, so some of the answers are I'm getting from the students, but not a complete answer here. We have to go for parathyroid hormone analysis or assay in this case for two important reasons. One, if we if the patient for example already gone for surgery, you need to uh, go for biopsy, for example, just like this case what we are talking. Then when they go for this thyroidectomy, accidentally the blood supply to the parathyroid gland may be interrupted, or sometimes even parathyroid gland may be accidentally removed. Okay, so to check for the status of the parathyroid gland, we can check parathyroid hormone. This is one explanation you can give. Another one, MEN syndrome. So it may be a part of MEN syndrome, multiple endocrine neoplasia. Remember, medullary carcinoma of thyroid is a member of MEN syndrome, whereas parathyroid hyperplasia is also a part of MEN syndrome. So there is a connection between them. So that's why we need to go for it. This type of case may be asked to you in your future exam. Okay, please remember this. Coagulation study like INR and PTT has to be done before any surgery. This type of tests are the must. We need to go for bleeding profile and the clotting profile of the patient. You can answer like that. FNA of nodule is usually we usually do it, though in case of follicular neoplasm, these are not very helpful. CT scan of neck should be done. And then these are the different imaging: ultrasound, CT scan of the neck for surgical planning. CT scan is a very important test if we believe this is a malignancy, because it will judge what is the size of the nodule, and it will also tell us is there any metastasis occurring in the nearby area or any local infiltration there or not. Now look here. So here is a thyroid mass. Okay, this is the trachea, and this is thyroid mass there. Now, finally, how we are going to treat a case of thyroid nodule. We start with the medical management, and medical management depends what is the status of that thyroid nodule. Is it hyperfunctioning or hypofunctioning? Or overall thyroid gland, what is the status? So accordingly, we'll plan our management. If this is a case of hyperthyroidism, you have already answered me. We go for those medical treatment. If this is a case of hypothyroidism, we need to supplement thyroid hormone. Okay, so see that the same thing is written. Now, iodine 131 treatment is done for medical thyroid ablation, means destruction of the thyroid gland. And this is a very commonly used treatment all over the world, especially for hyperthyroidism. And you observe for the benign nodules. Now, second management is a surgery. If we have a failure of medical management, there is no option, then surgery, we need to go for it. If malignancy or concern for malignant potential is there, then you have to go for surgery. Don't delay it, because we need to diagnose malignancy quite early and go for the appropriate treatment. Symptom management means if the patient is having dysphagia, if the patient is having difficulty to breathe, for example, patient is having stridor, then we know the mass is too big and it is compressing those structures there. So decompression surgery has to be done. A part of the thyroid gland, okay, is sacrificed there. This is known as symptom management. Now, after the surgery, okay, this is called post-surgical therapy. Iodine 131 is again given post-operatively for any residual malignancy. It's what? If anything is left behind there in the thyroid gland, or if there is any metastasis which has already occurred, then this iodine 131 will be uptaken by those malignant cells and they are destroyed because of this important substance. So this is a very important concept here. Thyroid hormone replacement should be given after total thyroidectomy because there is no more source of thyroid hormone in the body. And remember this, if we suspect we have damaged the parathyroid gland, we have to give calcium to the patient. You don't give parathyroid hormone, rather than that you give calcium, because the function of parathyroid hormone is raising of the calcium level. So you give calcium to the patient and that will take care of the calcium homeostasis. Ensure your patient has endocrinology follow-up. That is, titrate the levothyroxine and help manage long-term iatrogenic hypothyroidism. What does that mean? Now you have already removed or destroyed the thyroid gland, and patient has converted into hypothyroid state. So give levothyroxine. Okay, call the patient after a few weeks just to make sure whether that dose is enough for your patient or not. Now, this is an algorithm of the thyroid nodule case. Okay, so let's quickly go through it. See here, there's a thyroid nodular mass. You can go for FNA after thyroid function test, which we have done. Is a benign mass, okay, or malignant or suspicious. Accordingly, your management will differ. In benign, you follow it clinically. You don't need to worry much. But if it is a malignant mass or suspicious mass, you definitely need to go for surgery a bit earlier. Okay, get a tissue pathology, confirm it that it is a malignant, a tumor, then go for the definitive treatment. If this is an in between, which is known as indeterminate, you repeat FNA or repeat the biopsy. So this is a good algorithm to remember. Now, finally, what are the complications of thyroidectomy? Very important questions from the exam point of view. See that, please. Okay, they are intraoperative complication and postoperative presentation or complication, you can say. Intraoperative is bleeding, and this is very difficult to control. This is called primary hemorrhage. It occurs during surgery, but we can minimize it. If the surgeon is doing it nicely, the surgeon will minimize it definitely. And sometimes there may be damage to the arteries and veins of the neck, which are very nearby, and that is a fatal complication. After the surgery, okay, we have to examine the hoarseness of the voice, or we have to examine the larynx just to make sure whether recurrent laryngeal nerve have been damaged during surgery or not. And sometimes, okay, these are damaged. So next morning, when the surgeon comes for the round, they ask the patient to speak something and check for the hoarseness, and they also do laryngoscopic examination to make sure the movement of the vocal cords are fine. Another is check for the bleeding. If there is expanding hematoma, it causes compression and shortness of breath. Now this expanding hematoma is a feature of reactionary hemorrhage, which may occur within 24 hours. Hypocalcemia may occur if there is removal or injury to the parathyroid gland or their blood supply. So we need to check for it. And sometimes patient is already having the features of hypocalcemia like tetany, like twitching of the muscle, and it is very easy for us to suspect. And finally, there may be scar formation on the neck, in the anterior part of the neck, which doesn't look good for the many patient. So they don't like any scar on the anterior part of the neck. So these are the known complications of thyroidectomy.